thanks to Dr. Abassi, I actually I'm at a conference in a spine conference in Las Vegas and I had an unexpected change in the schedule. So I appreciate you guys letting me jump on and give my quick talk here. And I am just honored to talk to all you guys across the world, excuse me, on Transkambin surgery. And I've been doing Transkambin surgery since 2016. And just going to quickly talk about my experience in this approach for revision surgery, which I think is truly where this approach shines in spine surgery and how I think how applicable it is to revision surgery and yeah, let's see if I can get this going here. There we go. So like I said, I've done over 600 transcranial fusions since 2016. I do about 10 a month. I've taught 75 surgeons in the US this approach. And of course, we all know kind of the trajectory and how we do transcambin surgery. And if you know me, you know that I like to make videos. So this is a little video on transcambin. We make it look cool. So actually, you can do a fusion in just 20 seconds. No, just kidding. But so basically, when we're talking about transcambin surgery, obviously we all know the benefits, and all of you guys have been celebrate this amazing approach and why it shines over other approaches. But the thing that I think that is awesome about the approach is it's so easy for revision surgery. And this is just a case example of how it can perform in a primary surgery. This is a patient with a spondylolisthesis at L4-5, a little bit of foraminal stenosis. She came in with right leg pain because she has this asymmetric collapse of her right L4-5 disc. She failed conservative treatment. She had a mobile spondy there. And you can even see on this AP and the lateral x-ray intraoperatively before I even did the fusion how well that asymmetry was corrected by just the transcambin approach and implant. I did percutaneous screws, did the decompression, and then this is a anterior posterior surgery in an hour and a half with 5 cc's of blood loss, and she can go home the same day. So just a truly, truly amazing approach. But we know it's great in those cases, but what about the hard cases? So, you have cases like this that come in, or at least I do. This is a patient, like a 72-year-old guy, came into me for severe, debilitating left leg pain. He's had 5 back surgeries. This is his x-ray. This is actually scalp from the CT, but this is what his x-ray looked like. He had a revision surgery at 2-3 to help him with his pain. His pain got tremendously worse after this procedure. He was in a wheelchair. And on his imaging, this is what we see. He had this kind of abandoned 4-5 fusion, 3-4 fusion, and then this is his new fusion at L2 and L3. And you can see osteolysis around the end plate here of the 2-3 interbody spacer, and then his sagittal CT, the screws haloing significantly around the screws, and you can even see that on the coronal here, or the hailing around that left L2 screw. The screw is medial, in my opinion, too, and I think is one of the reasons why he was having this intractable pain. And so, you can see the on the coronal view where the implant is off to the side, there's no bony fusion mass at all. And the other thing is that there was no, the facets were taken down for the decompression. So these are challenging cases. I did a transcambin approach on the opposite side. You just take a steeper trajectory to that disc base, come lateral, through the cambins and drop an implant, right beside it. And this is, takes 20 minutes to do that procedure. This is the approach that I use. This is a different patient, but you can see where we just took a slightly steeper approach, did the right as the intraoperative balloon placement of where we would put the implant, in the left image there as the implant after it's placed. This is his final x-ray. I also revised and replaced the screws, put a bone stimulator in there, bone growth stimulator, because of a pseudo. And his surgery is in 2019. We did the entire revision. I do transcambin open and minimally invasive. I do the implant perk through Cambins, and then I did the revision, fusion, open, and this is his X-rays. And immediately after he woke up from the surgery, just complete relief of his pain, and it's done great. I actually went back in. He had a spinal stimulator done before he came and saw me, and I was able to remove that because he didn't need it anymore. Um, Here's an even more complex case. This is a 65-year-old lady who came to me. She had had multiple surgeries. She has had 5 revision surgeries for this construct alone. She kept having failure and a rod breakage at the thoracolumbar junction, severe persistent thoracic pain, and no surgeon. She went and saw another surgeon, and no one would really help her with her pain. The primary surgeon had done the rod breakage, had actually passed away, and so she came to see me to see what we could do. And her hardware was intact. And, clinically speaking, there was nothing wrong with her hardware or anything to revise per se. We did a CT scan. And here you can see, if you take a real close look, you can see at several levels that I have starred that there's gaseous changes within the disc space. So clear motion there. And that's where her rod breakage was. So, what would you do in this case? You could punt it, tell her there's nothing that you could do. You could run, and that doesn't really help her at all, but it helps you. So for me, what I did is I talked to her about doing a Transkambin approach. So I navigated 3 implants into those spaces. Of course, this is off label, but 60 minutes, 1 hour of surgical time, 0 blood loss. She went home the same day. I did a chest x-ray in the PACU to make sure no pneumothorax. Here is her imaging 3 years later on the right side. You can see all no more gases changes within the disc space. She had complete resolution of the pain in 1 hour after surgeons had done so many different revisions for her. And here's another case example, 62-year-old guy, L4-5 fusion in 2021. He had 1 year post-op, he had pain, and then 6 months progressive pain. I don't have all the imaging on here, but you can see he has a synovial cyst adjacent to his 4-5 pain. And he actually had a pseudoarthrosis at 4-5. So he had a pseudo at 4-5, adjacent segment disease at 3-4 with a large symptomatic synovial cyst. And you can just kind of see the MRI there. And so what I did in his case was in a single approach is dropped a Transkambin fusion implant at 3-4, which is the synovial cyst level, and then augmented his 4-5 pseudoarthrosis with the implant right beside the old TLIF. And here is an intraoperative CT. You can see where just placing that right beside the implant at 4-5, and yeah, and he did great. Here's another example. On the right, you can see the coronal images of a failed pseudo at 4-5, and there's a peak implant at 2-3. And they did a posterior lateral fusion at 3-4. He had a multi-level pseudo, and this is his post-op CT at 18 months post-op. So just reverse robust fusion in this patient. And the remaining time I'll have just a couple of X-rays showing how we approach this. Again, it's just a slightly steeper approach. There's another X-ray, more pictures of a pseudo. In the U.S., we have a lot of surgeons that do. I don't do unilateral pedicle screws, but it seems to be a popular trend. And those patients, in my opinion, just don't have the biomechanical support for fusion, and they tend to break down in these TLIFs. There's a picture of the implant right beside the old TLIF cage. So yeah, thank you, Dr. Abbasi, for having me here today. Thank you for letting me kind of jump on here at the last minute and interrupting y'all's conference so I can get this talk in.
Well, thank you so much, Betsy. This is always a pleasure having you on board. And you have mentioned few things that I need to reemphasize. You take care of patient that nobody else wants to take care of.
Mm-hmm.
And not because the other surgeons are bad surgeon and so on and so forth, but because you have a tool that reduces the risk associated with surgery, and in the balance between risk versus benefit, you just, with your technology, with your skills, you can help a lot of patients. Now, my question to you is, what percentage of your patients are patients that other surgeons have rejected? And what percentage of your patients are actually revision? Now, you get, I'm sure like me, you get a lot of patients that they didn't have a previous surgery, but they are elderly, they have comorbidities that other surgeons agree something needs to be done, but they say it's just not safe to do the surgery. Unfortunately, sometimes when the surgeons say it is not safe to do the surgery, they mean it's not safe for my practice to do the surgery. Meaning,
Right.
because we know for the patient, if they are in pain, they're suicidal. They don't want to live. They if they start if they stop ambulating, their life expectancy goes down. So, but your practice, number one, what percentage is the revision? What percentage is the reject of other surgeons?
I think about 50% of my practice is revision. It's a big component of my practice. And I wish more surgeons did exactly what you said. You have a problem, but I can't fix it. I think you need to go see X surgeon. What I tend to see, and I really just hate this approach, is, a surgeon may just tell the patient there's nothing that can be done. And then they accept that as what the opinion may be, and they may not go seek another opinion. So or they tell them that it looks good when it clearly doesn't, acknowledge the pseudo, or they want to shield themselves from being subjected to having to revise it, or the patient expecting to them to revise it. So I wish more surgeons were honest with themselves and told the patient, hey, you have a problem. I think you need a revision. I'm not skilled enough to handle it. I want you to go see this surgeon. But I just don't think a lot of us are honest with ourselves as surgeons to do that. But the patients that I see are ones that, maybe decide that they want to go have another opinion. And I think that's why it's important to really encourage patients to get a second opinion, because there are surgeons, not saying that we're better than the surgeons that do any other approach. It's just a skill set that is really, really great for certain problems. And in these TLIF revision surgeries, this approach is phenomenal. So.